So we know this course is officially named Mastering Advanced Intraosseous Injection, but everyone needs to know that you can also use your high-tech units for conventional methods. So just keep that in mind, and we'll go over that briefly as well. So of course, I want to give a lot of thanks to Dr. Prin. He spends a lot of time with me on the phone. We converse frequently. It works gloriously because he's actually currently 4 hours ahead. They did daylight savings time, and I'm a super early riser, so I catch him before his day kicks off. But he's been a great mentor, and I also recommend you all reach out to him. I also want to thank my doctor team at Carolina Pediatric Dentistry. They have been riding this dental high-tech wave with me for 7 months now. And I think that they have really adapted well, and they've also been a great resource for me to understand what common glitches and hangups are and where they hit their strides and where I need to do a better job explaining. So special thanks to them. So I want to let everyone know this was initially going to be just a straight advanced class, but I know there's at least 20 people on this call who have a dental high-tech unit, who haven't used it yet, and have not actually attended any webinars from what I understand. So we're going to do a brief review. There's also some people that were with us 2 weeks ago that asked to review things again and elaborate a little bit more. So it's going to be a bit of a hodgepodge of a review and some new things and a little bit in depth on the techniques and so forth. So just to kick it off, I know that most people on this webinar actually have a SOAN, but we do have some that have a sleeper one. We do have in our practice both. We have a sleeper one and we have a SOAN. And the reality is the sleeper one functions, they both are the same thing. The sleeper one's just more straightforward, less settings, it's corded, and I will show you there's the main detail about it is that there's 3 colors to choose from. So number one question I get asked via text and email is, does it matter what color you're on when you step on the inner pedal? And the answer is absolutely no. The inner pedal, despite the color, is just drop by drop. So you will always have drop by drop if you step on the inner pedal. With the sleeper one, there's 3 colors. I added little color tabs on here because I think maybe I didn't put enough emphasis a couple weeks ago. But blue is for bone, B bone, B bone. Always remember that blue's for bone. So it's intraosseous. Theoretically, if you read your manual, it'll say that pink is for interligamental and palatal, but if you're being super compassionate, you can start with blue, then switch it to pink and do that. Pink primarily for me is for infiltration when I am unable to poke through the cortical plate to get into the cancellous bone. And then orange, and this is so very important. You absolutely have to use orange for your inferior nerve blocks because you cannot aspirate at all unless you are in that orange setting. The other thing to keep in mind with sleeper one is there is one pedal setting, and that is drive. You drive it just like you are in your car and not on cruise control. So everyone remember that. For aspiration, it is very important to know that for the sleeper one, you only have one way you can retract your plunger, and that is that upper left button, but that's also your aspiration. And everybody's going to do this if you haven't done it yet. If you try to aspirate too quick, you will simply retract your plunger. When you aspirate, you press and hold, and you'll feel it. You'll feel it actually pull back. You'll feel it aspirate a little bit, and then you can go back to the 2 pedal, the big pedal, and begin driving again to unload your cartridge. And in order to aspirate, you have to use at least 1/8 the cartridge. And I think for me personally, this is probably my most super common error. We're going to talk about this a little bit more in a bit, because we're trained when we think we're by the inferior alveolar, we inject slowly. When we think we're where we're at, the first thing we do is aspirate to make sure that we're not intravascular. So again, to aspirate, you have to hold a bit longer to make that happen. And I see something in the chat. So, oh, that's you guys. All right, I'm going to ignore that. So just interrupt me. So go ahead. It was just you. Okay. So again, I just want to reiterate, it doesn't matter what color you're in, the colors all correspond to petal 2. So just remember that. And there's 3 colors with indeed your sleeper 1. This diagram shows on the back of your sleeper 1, it came with the little screw and it gives options. I liked the digital version better, even though it's in French, so I'll explain all this. Basically, in your different colors, you can switch to an option that heightens the curve and the speed. My very strong recommendation is just forget about it. Don't complicate your life, throw away the key, and just forget what that's for. Because the reality is, once you get into the orange setting, it already is higher than depositing 1 milliliter per minute, which we know is the super kind way of delivering local anesthesia. Theoretically, if you're doing an inferior alveolar and you've already deposited this slow slope, they shouldn't feel it, but there's really no reason. Life's too short. Don't rush through everything. Just take your time and deliver your compassionate anesthesia. So I say, I wouldn't change this if I were you. Oh, and I will tell you, if things are going well, options you have if you want to speed it up are simply to change the color on the upper right-hand side of your pedal. And it's very easy to do that by just clicking on that upper right versus changing the whole setting on the back of your unit. All right, let's talk about the SOAN now, because almost everybody has a SOAN. So the SOAN is basically, like I said, functions just like the sleeper 1, but you have all these extra bells and whistles and things that you can do. It is cordless. It is a little bit heavier. A lot of people say, what do you tell the kids when you're coming at them with these things? I think it looks like a thermometer. So I just got in the habit of saying, I'm going to take your tube's temperature. And I think a lot of our doctors in the office now say that. And the kids are like, oh, okay. They really don't feel it if your technique is good. And if they are distracted, maybe a little nitrous, maybe a little TV, all is well. So we'll go into the specifics. So there's 5 options we really can choose. Sound management is the first one. You can alter that. I personally like to hear the beeps, and I think it's a good way to signal things. I also think it's a good distraction for the children, like, oh, did you hear that? And then it makes them, maybe if they want to be a little fussy and sing a little bit to us, sing as meaning cry a little bit, they stop for a second so they can hear, maybe breathe nitrous a little bit more, settle themselves down. I like to hear beeps. I like to hear beeps on my curing lights. I like to hear beeps on my dental high-tech units. So I would say leave the sound on. That's a personal thing. Quantity pre-selection. The only time I would really get into this, and I've gotten now where I'm so comfortable, I know how long it takes for the device to stop after I take my foot off the pedal. So I really don't use that and preset it anymore. If you had a very small child, let's say it's a sedation, and you're really monitoring your local anesthetic, that could be a very valuable tool for you. But I'm not going to go into those settings for that today. Time before shutdown.
Hey, LaRee. Sorry,
Yeah.
it looks like we have one question already.
Perfect.
From Dr. Ron Paulos, and I apologize if I mispronounce anyone's last names here. It says, with traditional injections during the aspiration process in the high setting, the push rod for the sew-on moves away from the carpule plugger. Plugger stops when I remove my foot from the pedal. Not sure if that aspiration is occurring. Makes me a lot uncomfortable for traditional injections. Any help or comments?
Absolutely. I'm so glad you asked that. And I will say that has been a common thread. I've had a few doctors tell me that they weren't feeling good, that the aspiration piece actually works. So during this course, I'm going to demonstrate that. And we're going to get into that into detail, because that was a common thread that people personally reached out for me. So thank you for asking that. We will get into, I promise we'll get to that in just a minute. So time before shutdown, again, I wouldn't mess with it. I've never had an issue. We use these things all day. Sometimes there's 2 doctors in our office, just constantly they're in somebody's hand. We don't have any issues with batteries. I wouldn't even worry about it. We talked about adjustment of injection speeds. It's a different way of doing it for the SOAN. I wouldn't touch it. Here's the big one though, the mode operation on the injection pedal. I think that this is probably something that really messes up a lot of people. So understand that your unit came in cruise. And so cruise means you step on it once and you take your foot off and it's just going to go. And I will tell you personally, those of you, most of you probably on this call know me very well. There's no shame in my game. I will tell you all the dumb things I've done to help you avoid them. And I've done things like thought I turned it off, that it was in drive, and set it aside, and it drains the carpule. It was still going. I mean, you name it, I've done it. And so I would personally recommend while you're learning this that you switch the unit to drive. And I'm going to do a demonstration. Actually, I videoed my practice partner doing a demonstration of this so that everyone can know how to fix it. He also had the bright idea, Clark Morris, my practice partner, that because we have a sleeper one is, well, we have multiple sleeper ones, and we have multiple SOANs in our 2 locations, that we just set it for drive because it gets confusing the doctors when they pick up one, there's no choice but drive, but maybe they pick up another and now it's on cruise. And then the other thing to know is if you just look at it, you really can't tell until you start using it. So I would recommend, it comes preset for cruise, that everyone switch to drive so that you are in control. And it's sort of like I have very young adult kids, and you don't put them in the car and teach them how to drive and then just like hit the cruise control and have fun with that, see how it goes. At least not in the cars my kids drove. We didn't have those fancy like placement settings where the car slowed down itself. So I would recommend everyone switch to drive, and we'll talk about that in just a minute. So speaking of, so we're going to do this, and this is going to be a video of Clark showing how to do it. So this is the manual. It's on page 15, and it is the second part. It's not really intuitive. So rather than looking at the manual, I would listen to Clark. And if you guys have any problems hearing him, just let me know.
So the SOAN comes defaulted to cruise mode. Right? Access. White button. All green. When I press the when we're fine, that press the triangle button. Now you're in drive mode. Button. Drive mode.
All right, so hopefully everybody caught that. It's a little bit wonky learning the settings on this, so just try this. And if you need me to send you this video, my contact information will be at the end. And if I had to guess, I bet Jordan and Chris have it too, that they can text people so everyone can understand how to do that. All right, so the pedals, talking about the pedals again, the middle pedal has nothing to do with color. It is simply drop by drop. And again, it is just for mucosal anesthesia. That's all we're doing. So blue again, B, bone, blue, intraosseous. We're not going to get into intraseptal. Dr. Print and I actually talk about this a lot. It's something they use a lot with what he does in adults and the quick sleeper. But for us pediatric dentists, and we're going to get into local anesthesia a little bit later, we are trained to use 1 to 100,000 epinephrine. And truthfully, if you're going to do intraseptal injections, you need to invest in 1 to 200,000 epinephrine, because we don't really want that much solution deposited in one place that doesn't have the ability to diffuse. And we'll talk about anesthetics a little bit more, so I wouldn't worry about that at this time. And then the pink, I have a little asterisk by intraosseous. Sometimes some children are doing so well and they're so oblivious to what's going on. Dr. Alp taught me this technique. He's like, if they're doing really, 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 really great, just take your foot down and switch it to pink, and it'll speed things up just a little bit. But truly, if you read your manual, the pink is for infiltration and inferior alveolar nerve blocks. So again, you cannot aspirate unless you are in pink on your SOAN. So just keep that in mind. There's two ways that you can retract the plunger on the SOAN. You can retract it by a faster tap on that upper left button, or you can do it with the triangle on the handpiece itself. So if you have a sleeper one, remember before you get up and you're done with your friend that you need to click that for the dental assistants. Otherwise, if your patient's doing their, 5 minutes of oxygen at the end of the case, they're going to have to climb over everything to get to the provider side of the chair to retract that button. If they're using the sleeper one, if they have the handpiece, they can just hit it. But again, aspiration must be on pink. You must have used 1/8 of a cartridge and hold on a bit longer to get that aspiration. So,
Hey, LaRee.
yes.
Sorry. It looks like we have a couple more questions, and we do have a raised hand as well.
Okay.
Okay, so never mind. The 3 Q&A comments were just that it was a little hard to hear Clark.
Mm.
So maybe we can go back and play that again at the end. So we'll get that taken care of. And then for everyone, if you guys have any questions that you want Dr. LaRee to answer, feel free to submit them via Q&A, the Q&A function that's down at the bottom of your screen. And then that way we can ask as she goes. Dr. Atzman, I see that you have your hand raised. If you want to submit your question that way, you're more than welcome to.
Are we good, Chandler?
Yep. Sorry, go ahead.
Okay. Just making sure. Okay, so LaRee, these are questions from our colleagues. Have you seen a positive aspiration? No, I have not. So how do you know it works? Well, there's a couple things. Even before dental high tech, I mean, we see positive aspirations, but it's not every day of our practice life. And then if you take the biggest age group that we see in our practice and know that for 7 months, I've completely eliminated in that younger age group inferior alveolar, I really don't give myself a lot of opportunities for positive aspiration. So no, I had to be honest. No, I haven't seen it. Well, how do I know it works? Well, that's a really good question. So I brought it up with Dr. Prin because a lot of people ask me this, like, what if this doesn't work? What if we cause a seizure? What if this happens? So Dr. Prin and I talked about it, and he's like, you know what I want you to do? I just want you to take the SOAN and, stick it in some kind of red fluid and aspirate and pull it back into the syringe proper. So I will tell you that doesn't work because it's not a vessel. It doesn't have pressure. So I was like, well, how can I do that? I like squeezed a ketchup packet, like super, super tight, tried to make as much pressure as possible. Well, guess what? That didn't work either. And I was talking to one of my dental assistants and I said, I hate that this is a barrier for so many of our colleagues, but I really don't have proof that this aspirates. And she's like, well, just stick it in my vein and aspirate me, because she loves kids so much and knows how great this is for kids. She's like, I want everyone to use this. It's so much nicer for the children. I was like, really? She's like, yeah, I don't care. Just do it. I want you to show everyone. And so I am phlebotomy certified because I had a series of children, specifically those on the spectrum, that were either being sedated or having an office general anesthesia, and the physicians wanted labs and I didn't have the means to do it. So I am phlebotomy certified. I was like, well, okay. So here's a video of me sticking one of our dental assistants to show you that aspiration does indeed work. So here we go. We're going to do this. So I'm letting it get to more than 1/8 the carpule. I will tell you, this made me a little bit rambunctious. And the first time I stuck her, I didn't let it go 1/8. Then this is on cruise right now. So I wanted to show everyone, I just stopped the cruise. So you see it stopped. There's no more anesthetic flowing. And then that's the button on the upper left. So I have a glove serving as a tourniquet. And you can see where I poked her without using a full 1/8 and it didn't work. So I'm poking her again and I'm stepping on it now. And everyone sees the blood aspiration. The aspiration function works very, very well on this unit. So I and Janet both attest that we have had a positive aspiration. And I can tell you, when I hold it in my hand, it feels just like the sleeper one. You can feel it. It'll sort of spin the carpule just a little bit, and you can feel it when it aspirates, and it beeps too if you have the sound settings. And there's her positive aspiration. So of course I didn't inject into her because that's not cool, but I injected enough, and you can see she had 2 little dots on her hand because the first time I did not pass the 8th, the carpule. So a lot of people have contacted me regarding they don't like that. You have to do an 1/8 of a carpule before you can aspirate. So one of our doctors, Dr. Kolaski, she came up with the 8 carpule hack. So she uses part of the carpule someplace else so that she can immediately aspirate when she's doing an inferior alveolar. And then obviously I used a very small needle in Janet. We wouldn't use that size for an inferior alveolar. But you could also just do what I did with Janet, just drain it to the 8th, because you don't really need to use a full carpule. And if most of the time what I'm doing, if I have, let's say a 16-year-old, I'm using 3/4 of a carpule, and I'm using that, other 4th or 8th for a long buckle. So just things to think about there. I want to make sure that answered everyone's aspiration concern there. It does absolutely aspirate. It's just very hard to emulate that without a type of vessel pressure that everyone has. All right, so what do the 2 and 3, I like the blights. This is the first thing, the blights, the blinking lights, or blights blinking like this mean. All right, so this is a video of these blinking lights. So you can see it's blinking up and it's blinking. So these devices are so smart. They're measuring the pressure of the injection resistance. And if you have too much pressure, it'll just stop and it'll retract the plunger, and it's game under. And it's a safety mechanism. And it's a good reminder sometimes that you forget you're not in blue, and blue is for bone, and it's meeting too much pressure. Or for me, if I'm in blue and my friend is doing so well, and I'm like, okay, we're just going to speed this up. And I reach up and I tap the pink and I see my lights a little bit more resistance, like, ooh, I go back down to blue and slow it back down so that I'm not pushing with too much resistance and allowing the solution to have the moment to diffuse. All right.
LaRee, sorry, I
Yes,
was going to interrupt. Dr. Tuttle had a question about no aspiration for intraosseous, correct?
correct. No aspiration for intraosseous. In fact, it will not work. If you're in blue, you cannot use the aspirate function. Good question though. All right, so can I use lidocaine? I will tell you that most of our colleagues that have reached out to me and just says, I feel like it kind of works, but not profoundly work. I would say not all of them, but most of them are using lidocaine instead of articaine. And we're gonna talk about articaine a bit in detail in just a minute. I don't know any reason why we wouldn't use articaine other than this. We know if we use articaine under age 4, it is theoretically off-label. And I think my next slide is going to talk about that. So there's brilliant articles out there. And I can tell you, if anybody has been practicing, more than 10 years, they will probably tell you that we were trained, we could not use articaine at all. But the times keep changing. And even Dr. Malamed has changed, and he has released a lot of documentation that there really is no reason not to. We were told back in the day, articaine was a neurotoxin. I mean, let's all be honest with one another. They're all local anesthetics happen to be neurotoxins if you really want to get down to it. But articaine is superior on so many levels. So first of all, the most common form is 4%. So it's stronger local anesthetic. And it's an amide just like lidocaine, but it's really interesting because it has this ester group on it. And I don't want to get into too much biochemistry here, but the hydrolyzation in the plasma by, the non-specific cholinesterases, it basically breaks down this anesthetic in the blood, and the byproducts are no longer active. But before it does it, the thiophene ring makes it, which is just, as you can see, is just basically a sulfur atom on there. it makes it more lipid soluble, and this allows it to pass through the bone so much quicker and more profoundly than using lidocaine. So for me, maybe straight up with you, I use articaine for all intraosseous, even 3-year-olds, even 2-year-olds. In my mind, if it were my child, I find it safer. It's not metabolized in the liver. It's more profound. It's quicker acting. I can use less. It checks all the boxes. So I would recommend that everybody use articaine. But I'm being honest with you, under 4 is theoretical off-label. Kind of like for years and years, we use fluoride varnish off-label. You know, it wasn't really supposed to be fluoride varnish. It was supposed to be a desensitizer. And there's all other sorts of things in dentistry. But I strongly recommend that you use articaine. And I think you'll have greater success. So the next thing to talk about is epinephrine. So we're all trained, I mean, super hyper trained, that the best way to protect a child is to make sure we don't use any less than 1 to 100,000 on the epinephrine side of things. And we know this decreases the diffusion, and it also increases the length of anesthesia due to the vasoconstriction. Now, sometimes back in the old days, before we didn't have intraosseous for the little bitties, that kicked us in the butt, because that's when they left and chewed their lips for hours on end because our anesthesia was so good. It also reduces toxicity via reducing diffusion and the rate of systemic absorption. So yes, that's a thing when you're doing conventional means of delivering local anesthetic. When you're doing intraosseous, what I predict, I think we will catch up with Europe, and they very routinely use 4% articaine, 1 to 200,000 epinephrine. And what that does is it allows a greater diffusion of the local anesthetic and allows more profound anesthesia on the peripheral edges of what our borders should be. So for now, I think I'm probably we are the only pediatric dental office that have 1 to 200,000. In all honesty, haven't really jumped in and started using it a lot. I think I'm going to reserve it for the bigger kids that I'm trying to get the local anesthetic to travel a bit more. But in the meantime, there's some solutions I have, because I hear what people are telling me, and I see a little bit of myself, and a little bit of it's a learning curve, and a little bit is just really learning to wrap your head around all the variables. So we're going to break this down and talk about some things. So this is one of Dr. Prin's slides that I really like. So if you're super close to the tooth, you know, let's say the tooth is here, you really don't have to use a lot of quantity, and you can only put so many things on one graph. I will also say, if this is a minor to moderate restorative procedure, you know, you're not removing the tooth. The tooth is not pulpally involved. You know, you can get away with very little on a very small child. The other thing is looking at the size of your child. And it was really fun for me yesterday in our practice. I was with 2 of our doctors, and my sole goal of being there that day was to be a good mentor to them, and not being the provider, and just being able to walk in the room and size up a child and like, oh, this is a good sized child. No, we don't want to just do, you know, the half a carpule. This child can take a full carpule, or whatever the situation is. What are you doing? Is it a pulpally, you know, involved tooth, and so forth? But just keep in mind the variables. But what happens is the further you get from the tooth, the more material you need to inject, because it's simple physics. It's going to fill the space. So if you're 2 teeth away, you want to inject enough where it's going to travel to where you're going, and it will diffuse gloriously. The further you want it to travel, this is where I think we need to learn in the US for intraosseous, that we need to start introducing the 4%, 1 to 200,000 articaine, because it will allow the solution to travel and get to those more peripheral borders of what we're expecting to be anesthetized. And then of course, 1 to 100,000 works well, but there's some little nuances that I've learned, and I'm going to share those with you guys tonight, that will really help you make sure, since you're not routinely using 1 to 200,000, what you can do to still achieve that profound anesthesia. And so I don't know if Vincent's on the call tonight, but he asked me last time, like, why are you using your hand? Why aren't you retracting with the mirror? And I call it the circle of safety. I never turn loose of, I shouldn't, never is a strong word, but I always have a hold of the child. And this little girl, this picture, I was looking at images on my phone. I thought, oh my goodness, and by the way, Dr. Prin uses his fingers as well, just for stability and so forth. But this little girl, she has a perfect circle of safety. And then if this were a syringe, it would definitely be dental high tech. She's really close to the delivery instead of way out on the end. I just thought that was funny. Just a perfect picture. So again, what are we doing? We're trying to hit the apices because that's where we're trying to reach the innervation that is going to enter the tooth. And Clark had this great idea, which I just thought was brilliant. These are his fingers, and I appreciate his help with this. This is a typodont in our office. And fielding some calls from our colleagues since our last webinar has been really helpful for me to wrap my head around maybe some things that are going on. One of the colleagues of ours said, I don't think this is working. I even wonder if I'm even intraosseous, because if I'm using a 9mm needle tip and I'm leaving 5 millimeters out of the tissue, and I was like, whoa, wait just a second, what? And that is a rule of thumb. If you're not doing intraosseous, if you're doing soft tissue anesthesia, whether you're aiming for the inferior alveolar, long buccal, whatever your infiltration you're doing, yes, never ever submerge a needle less than 5 millimeters in case you have a hub separation so you can retrieve it, particularly with an inferior alveolar, because we know the pterygomandibular muscles will retract the needle and disappear, makes bad things happen, all those things. Intraosseous is completely different. This needle is not going anywhere. It is in bone. If you have a hub separation, it's going to be right where you left it. And so 2 to 3 millimeters is all you need. And I would hazard to say, if you're 5 millimeters out of the tissue, especially if the tissue is swollen, you're actually not puncturing through that periosteum and getting to the cancellous bone. So strive for 2 to 3 millimeters sticking out. And if you have someone that's particularly swollen, even though we usually use the super short for the children, you might consider going up to the medium needle. But this is just a good example of seeing what you're doing. The other thing I want to point out, I field a lot of questions about, oh my goodness, I'm going to damage the developing permanent tooth bud. And again, if you're using this super short needle, I just don't know how you could even do that, how you could reach it. And even if it's wildly ectopic, there's an exception to every rule, and you would have a radiograph for everything you do. But even if it was ectopic, normally what we see is it's kind of between the roots. But normally those ectopic tooth buds are more anteriorly and posteriorly ectopic. They're not superiorly ectopic. So it's just something to think about. I wouldn't worry about that. Look at your x-ray and make sure there's nothing really weird going on. Number one, go between the teeth. Number two, and we're not trying to do intraosseous in the furcation of primary roots. That's just not what we're doing. But again, don't leave 5 millimeters out. You might not get through what you need to get through. All right, I love the manicotti. I got a lot of positive comments about the manicotti, so I brought it back this time. So again, we're not aiming for a nerve block. We're not doing a large bolus for infiltration. We're simply filling this diploid space, and consider it a cylinder, and we're filling it so it can surround the apices of the teeth and simply get to the nerves that we want to anesthetize. And this Dr. Prin's excellent slide showing when we provide anesthesia to the like an infiltration, and we're going through the tissue, we're going to get where we're going, but we're going to anesthetize all this tissue. And when we do it via intraosseous, we're basically starting within the bone, so we're not getting all this peripheral anesthesia, and we're still reaching our goal. And we're getting anything that's connected to bone is going to get anesthetized. So the diffusion rules of thumb are in the maxilla, 2 distal and 3 mesial. And in the mandible, it's only 1 distal and 3-ish mesial. And we'll talk about some variations on this. And I think there's there's keys with children. There's a few things in pediatric local anesthesia in the United States that are some little small nuances that might make a big difference. So if we are aiming to inject here, we should easily anesthetize these teeth. So if I injected half a carpule, I would be comfortable, I would anesthetize these teeth for standard restorative procedures, meaning fillings and crowns. But if I had pulpally involved teeth, and particularly a tooth that maybe I have double treatment plan, like, oh, I don't know about this. Is that actually going to be, am I going to find a necrotic pulp or something? I might consider, since I am only using 1 to 100,000, I might consider doing an additional injection, especially if I thought there was a chance I would be removing a tooth. And I'll show you some examples. But again, diffusion, not a very specific nerve. That's why we can inject on the midline and it spreads across very well. And this is what it looks like in pediatrics. So for me, in my hands, if I were doing this injection, I would be very comfortable in children, their tissue, their bony tissue is so cancellous. I would be very, very comfortable doing pulpal anesthesia and even potentially removing those front four, especially if I see palatal blanching. If there were an infection, and we'll show what that looks like, I would add additional steps. In this scenario, I would definitely inject again if I were removing, because I'm using 1 to 100,000 epi. If I were removing, say, primary canines, I can't imagine a childless young I would be doing that, but let's just say hypothetically, I would definitely do an additional injection to remove those using 4% articaine 1 to 100,000. And I'm going to start using 1 to 200,000 soon, and I will let you know how that goes. Similarly on the lower. So just to review, there's a lot of questions about an angle, and I think this helps a lot. And then Clark and I took some pictures. So again, the D is spacing out. This is a quick sleeper that none of us have, but we're blanching the tissue. So what we know about that angle is the angle laterally is 25 degrees and it's off occlusally 25 degrees in that direction. And then that's the line that we're going for the intraosseous, because we're trying to reach right in the middle of that cancellous bone and then fill that space. So when we're doing that, the anesthetic solution will dissipate and it'll slowly reach the apices of these roots, and that's what causes us our profound anesthesia. But if we don't use enough solution, there's not enough solution to capture all those roots. So we need to think spatially, how big is this child? What do we have going on? And to get the real big picture. All right, let's do. I wanted everyone to see, there was some question about the needle colors. The millimeters are on there. They're kind of hard to read, but green is the super short one. So the sure thing, the sure deal, the primary dentition, use that tiny needle. You can pop through intraosseous 100% of the time. I give you confidence. It's going to happen. When you start entering into the mixed dentition, there's some maturation of the bone and things get a little bit trickier. If you use the Dr. Alp technique of rotating that very effective Epitech needle, I'm getting to be more patient like he is, and I'm starting to learn exactly the perfect pressure I need to put, and I'm getting through a mixed dentition more than I used to. I used to bend needles more than I do now, and you will too. The other thing to think about is the higher you are on the crust when you're trying to get into the bone, the more cancellous the bone is. If you get off on your angle and you start coming more from the side, that bone is not going to let you in as well. So keep that in mind. The medium one, I primarily use for, infiltration if I can't get into the bone with children. Some people are telling me, oh, hey, on very young children, I can use that length for inferior alveolar. Well, if they're young, in my mind, if they're young enough where that's going to work for inferior alveolar, I'm not doing that. I'm going to do intraosseous because I didn't need to do that. So just kind of think about that. The longs, which the guys will correct me if I'm wrong, I think we'll have Epitech longs come December, and those are very good needles. But I will let you know your traditional needles that you use for inferior alveolar, you can use on your dental high-tech units. They're a little tricky to get on, but you'll get the hang of it. Well, let's be honest, your dental assistants will get the hang of it real fast. The only thing I caution you is they're really hard to get off. So I try to get our dental assistants, when they remove them, to be sure that they use a 110 or something and keep their fingers far from it, because they don't unscrew quite as easy. All right, so the needle design, I think that the compassionate delivery with dental high tech, it truly starts with the needle. If you're just like, intraosseous isn't for me, I don't know, I'm just old school, I'm not going to do this, and you only use dental high tech because the needles are compassionate, use Effitech needles, and because you're going to save your own hands and your joints from overuse, I mean, that would be a step up from what you're doing. And this just shows, I mean, they literally are like scalpels, and they work so well. And this talks about why that angle is so important, and the D facing out, because the D facing out ensures that the bevel, you don't have to go very deep for that bevel. And that's showing that 20 degrees that you're off laterally. And that'll keep you where the solution will go into the tissue with minimal penetration. And I mean, you just barely, I mean, you won't feel this. When I stuck that in my dental assistant's vein, she was just like, why don't they use these to draw blood? I mean, it was very easy for her. So just something to think about. Okay, so again, 20 degrees laterally off the tissue, 15-degree angle of your descent down into the tissue, so you don't have to go very far. I can tell you that pediatric dentist, Dr. Prinz says this, and I've watched him give webinars and speak in person, and he has videos of pediatric dentists. We take way too long doing that initial blanch on the tissue because we're also paranoid we're going to hurt a child. We blanch for days when we probably don't need to do that. I mean, I know I'm guilty of that too, but this is Clark doing the example of how we want to do the initial blanching. And then there's two examples. So both of these would likely render a good effect. I can tell you the far right example, entering at the crest of the bone, it'll be much easier to pop through, and you will be closer to the center of the bone. And if you get too far out on your angle, you risk actually going completely through the bone and doing a lingual infiltration. So just be mindful of that. So here's the needle diagram. So again, that medium needle for infiltration, the super short ones for everything, including intraosseous for children. You can use the medium one for intraosseous as well, but it's a little trickier to get with children with their little tiny mouths. It's a little tricky to get that angle to pop in, so be mindful of that. And then, of course, you want to use the long for infraalveolar. And some people will say, oh, I can use I can use the 16 millimeter, but if a child's small enough where a 16 millimeter will do the trick, you're better off doing intraosseous. It's just so much better for them. I also want to remind everyone, I don't think it's real clear in those videos, you don't do your initial blanching and leave the needle in and then swing it up. You come out and then you reinsert, because you will tear the tissue if you leave it in, and it's unnecessary. And I don't think you'll get the right angle either. All right, so primarily this is what we're using here for all these reasons. And then if we have to, we'll put our needle on. Something I've noticed, if you look at all the European videos, our wonderful colleagues, Dr. Alp and our colleagues in France, and they have these beautiful videos, you might notice that none of those kids have nitrous oxide like they do. I will tell you, in our practice, 90+% of all operative procedures are done with nitrous oxide. And so the nasal hood, couple of things. If you want it to work well, you want it really to be adhered to their nose, but it's hard sometimes to get the proper angle with your dental high tech. So sometimes I will really get it approximated on them well. I will crank them up, have them take some really good deep breaths through their nose with their mouth closed, and then I'll loosen it up a little bit. And then when I go to doing the injection, so I can kind of push it out of the way to get a better angle. And then obviously, you know, if they're being a little wiggly, as you know, some of our friends are, or they come in anxious or something, and they're moving around a bit, the circle of safety will be more important for stabilization and giving this to them. Once they realize something doesn't bother them, oftentimes they stop moving, but those are the barriers to ideal needle placement. So again, we are going to do the mucosal anesthesia and the periosteal anesthesia, then we're going to do the manual bone penetration, and then we're going to deliver that anesthetic. I used to use topical anesthetic on the anterior. I've completely quit using it. I just find the kids don't need it. They don't feel this. And again, the sensation, it's so true. When you pop through, it's like that juice box. You pop through, and then sometimes you're like, did I feel a pop? But when you come out, you certainly can tell that you've just come out of something. And if you're meeting too much resistance or it doesn't feel like you popped, just be mindful that you didn't accidentally start doing an intraligamentary. All right, so here's a good question. Sometimes I think the children feel pressure partway through the injection. What do you think this is, and how do I manage it? So here are possible reasons. So one, children that have bad infections will usually get a sinus tract. They'll usually erode through the cortical plate and the infection will drain, and it helps with the pressure. That's why we see kids with all these terrible infections. And sometimes they say it doesn't hurt. They'll say it did, but then it stopped. That's usually because the tooth has become necrotic, or they have basically eroded the cortical plate and now the tissue is draining. But sometimes they don't, and sometimes they're really, really bad. And there's a lot of pressure in there. And then we add solution to it. So then they're feeling even extra more pressure. So it could be that. The other thing is, if you look at the slope of how it works, you go slow, 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 and then it kind of picks up speed. And I think sometimes the kids are like, wait a minute, I feel that because the diffusion, we're maybe going a little faster than what the diffusion can note. And a good way to know if this is happening before the kid does that is to watch the little injection indicators on the button that I showed you a video of. If they're doing really super well, sometimes I'll switch to pink and then move forward with it. But if they seem like no, and sometimes if it even seems like too much, I'll just stop for a second, take my foot completely off the pedal. Just know this, every time you take your foot off the pedal, you start back at ground zero with this injection slope. And with the blue, it's not a huge increase in speed, but if you're doing, another, let's say you are in the sleeper one and you're in orange, or you're in pink, or you're in pink and you're so-in, you're going to start from ground zero and it's going to go slow. And if you haven't actually used your unit yet, you're going to find yourself like, even though you see the light flashing that it's doing something, you'll stop doing this after a while, but you'll be staring intently at the plunger and seeing if it goes past the letters on the cartridge and doing all this crazy stuff. But if you take your foot off the pedal, it's going to go back and start slow again, and then you'll see it pick up speed. So just be mindful, really mindful. The other thing to be mindful of is it doesn't just stop real fast. So I always take my foot off the pedal, and in my brain, I'll say 1 Mississippi, so that when I take it out, it doesn't drip in their mouth and doesn't taste bad to them. All right, so let's talk about one of our doctors, Dr. Rosie Wynn. She asked for some, show us some things, show us where you would inject. So this is a really sad situation. This is the same child, and I'm going to show you each side because I think it's a good example of okay, you need to think out of the box and think about what's going on. Think about what's going on inside the bone of this child. So this is just a terrible, and I had just washed out like a nasty piece of chicken from that little operculum that grew into the caries. That's why it's bleeding right there. But when I look at this child has wake up in the middle of the night pain, came in holding their little face. I mean, this is really hurting. They're holding their face on their left side. And what we see on the radiograph is, of course, internal resorption, clearly necrotic pulp. This tooth is not a candidate for anything other than removal, unless you do LSTR, which we are currently not doing in our practice. And so when I look at this, I would, if this were very straightforward situation, and let's say I am just taking care of removing this one tooth. Let's just for a second ignore L. And I consider that the traffic jam. I know that the anesthetic solution is not going to react the same way as it would if I was just doing restorative and this tooth didn't have issues. So I would come in and I would normally inject right there. But since there's this traffic jam, I'm concerned about what's going on in there. I'm also concerned that I know I use 1 to 100,000. And so I would also inject there, just to make sure I have covered all bases. Now there's bone completely around this tooth. So theoretically it should go all the way around, but I don't want to play around. I don't want to take a chance. And this kid came in with acute distress. So I'm going to inject in 2 places. It is still 100% better than doing an infraovular and then walking out with, potentially chewing a lip and so forth. Now I have this tooth in front that I need to deal with that looks like it potentially is pulpily involved. And I don't really know what the solution, maybe this isn't rooted through the cortical plate, but perhaps there's a void that's increasing the area in which my solution is going to fill it. So my brain, instead of being, the area of this, and I would normally do a half a carpule or whatever, and this child weighed about 50 pounds. So I'm thinking in my brain, how am I going to address this without continuing to inject solution in this one spot? And I need to inject on the other side too. To make sure that I wasn't robbed of all my solution on any loss of bone in this area and be extra 100% positive. And I am over the top, a little bit paranoid. I'm not even going to kid you. I probably would inject there. But knowing all these things, I don't want to inject an infection and then come back and inject where there's not infection. So in this scenario, I injected here, and then I injected closer to the 6, and then I injected there. And I did about 3/4 carpule in total. And I can tell you after I did that, so I did like a quarter carpule, because this kid was hurting, and there was some lymphadenopathy as well. So this child, I did that, and I went straight to the Woodson, I elevated, and I removed the tooth. And that whole procedure just took a couple minutes. So let's look at the other side on this child. So I call that the traffic jam scenario. I call this the exit on the interstate scenario. So many times you're injecting when you're doing your intraosseous and there's a fistula. And again, not a savable tooth unless you're trying to do LSTR or some periodontics there. So I know there's a good chance I'm going to inject and that solution's going to exit, or it's going to really want to take the path of least resistance and go out here. And here's another great example. See how swollen that papilla is? If you kept your needle 5 millimeters out of that, there's no way in the world you would ever even touch the periosteum. So keep that in mind. That's a tricky place to inject because of it. So you might take a little bit different angle right there. So knowing that there's an exit for my local anesthetic, and oh, by the way, I'm very comfortable with appliances and fitting bands, especially in anesthetized children. I actually placed a band and loop on this partially erupted tooth. I actually put a raincoat on it and sealed it and placed a band and loop very carefully and meticulously. But when I'm thinking about this, I'm wanting to inject there because first and foremost, I'm going to get a little anesthesia for that. But I know I'm going to probably have some exit. I'm going to have local anesthetic, taking an exit and going completely off road to where I want it to go. So I am going to go here. And I know I might need to take an approach that is not the angle. I might need to come out a little bit more and head in. And then based on what happens when I'm doing all this, I need to consider, sometimes you'll see purulent come out and all sorts of things. This tooth was very mobile. By the way, this tooth didn't have a toothache because it was draining, or it didn't hurt as bad as the other side. So the kid just said, oh, this side didn't hurt. So I might even consider one there. And again, I did 3/4 carpule on this side, and I called it a day. I think I went a little bit, since there wasn't any lymphadenopathy, I went a little bit less. I did use 1.5 total for this 50-some pound child of articaine, 4%, 1 to 100,000, and then just went straight to it. And I removed this tooth, I went to the other side, and then isolated this with the raincoat and drove on. So that's how I inject. So here's another great scenario with, again, this is kind of everything. There's definitely a lot of infection here, but then we have this nice exit. The whole entire root, as a matter of fact, is exiting. So when you see a situation like this is some kind of chronic business. And guess what else it does? It extends past the mucogingival junction. So when we do our intraosseous anesthesia, so if we were doing minor restorative here, we would inject right there, call it good, and just be completely done with it. But this is chronic. There's a traffic jam, an exit, and there's also an area beyond the mucogingival junction that is just not going to be achievable through intraosseous. So I did indeed do that there, but of course I went distal, and then I did just a little infiltration around the area that wasn't on attached gingiva. So we just have to think about all the pieces for these kids. But again, by doing it this way, I immediately was able to just get to work and obviously remove these teeth. So someone asked me to again review all the issues and all the things that we've learned in our office, so that you can avoid them. So number one is make sure that your team does not throw away your clear containers that should be autoclaved. They kind of look disposable to some people, evidently. Number one. All right, number two, read your manual cover to cover. The pedals are unit specific, so make sure they stay with their hand pieces, because that is a thing. Another thing to know, the sleeper one, if you're like our office, and I'm not sure anybody, Jordan, does anyone have both like us where they have sleeper one and sew-in, or is everyone pretty pure?
For the most part, it's one or the other. To my knowledge, I don't know of anyone who has both. But if so, please.
Okay. Well, if you do like us, just know the containers are not universal. There is a sleeper one container and there's a sew-in container. So have the right container and don't mess that up. If you're out of Epitech needles, don't surrender. Don't go back conventional. Just use your other needles, but they will not be as comfortable. Bent needles are a thing. It's okay. You'll get where you are better about not bending them, or maybe it's just a sign you need to switch up and go conventional. Maybe not profound anesthesia. We talked about all the things about that. Sometimes it's hard to know what exactly is going on. This will be one of these things where you start getting into the groove. You size up the child, you size up the infection, you size up the procedure, you start doing it, and it gets easier and easier. Yes, the plunger retraction is slow. We are such impatient people because we have little people sitting with us and we want them out of the chair super fast. So retrain your flow with your ops, stay with your ops, don't get up and walk out. So if you have a lot of recares and you're like, oh, in the old day, you're just gonna run in there and sleepy them, and then you're gonna run back out and check on your recares. No, check your recares and go in and stay put, and then don't get up again until you dismiss your op. So again, the cruise mode, you must stop it before you can aspirate with an infraalveolar. And I've done this, and of course it's not a big deal unless you're on cruise, but I will push my high-tech pedal instead of the rheostat and get that cruising. And then I will, unfortunately, I've learned that kind of the hard way, if I have very complex pulp zirconia crowns or something, I used to anesthetize 2 quadrants and then I would fix them. I would recommend with dental high tech, you anesthetize, fix that quadrant, because you're going to work immediately. Then you're going to anesthetize, fix that quadrant. And it's very smooth and fast. Of course, unless you do like I did, have it on cruise and touch that pedal instead of the rheostat. So I pick up that to go back to do the other quadrant with half of my anesthetic and it's gone. So learn from us, don't reinvent the wheel. So again, just real quick on this decision tree, you're set for primary dentition. You don't need to do anything. You can just usually 1 injection, straightforward measures, half a carpule, do what you need to do. It's really going to do. If you have an infection, you might need to do more. Keep that in mind. In the mixed dentition, depending on the maturation of the child's bone, kind of changes things up a little bit, but you should be able to get in. But due to the size of the child and the fact you're using 1 to 100,000, your anesthetic may not travel as much. So you might choose to do another intraosseous at the terminal area of your anesthetic realm. Late mixed dentition is a bit hit or miss. You can also consider, Dr. Alp doesn't do any inferior alveolar because he does all intraligamentary. So just go slow to be pro. You can consider doing that. He doesn't remove any permanent teeth. We do a lot of molar substitutions and a lot of surgery in our office. So I generally will, if I can't do intraosseous, I will switch to conventional. And then we're going to late, mixed intuition and permanent. You know, you can go, sometimes you can still get in. My oldest that I've been able to, and I think it was the SOAN, get in intraosseous, was a 20-something-year-old special needs, very tiny young lady that had a lot of things going on, probably a little, unfortunately, probably a little osteoporosis, but it was really great because I was able to skip a block. So last time we talked about this kid, and someone asked, can we just see it slow from the beginning? I don't want to keep everyone through the whole webinar, and we can go back and go through very slow, just like how the whole thing went, what it was without speeding it up. And we can also go through switching the modes with Clark if you want to do that in a second. I can go in more detail. There's been some people that are like, will it be more than an hour? Because I only have an hour. So I just want to hit those things. I went through these a little bit. I want to review what the bent needle went with. Someone missed that last time. This was a child that I will do this sometimes. I'm like, I don't think I'm going to get in there. So I will conventionally infiltrate, and then I'll at the last minute try to do an intraosseous. This was a pretty developed little girl, and my instinct was right. I couldn't get in, but I like it when I can do it because then I can get started right away. And this was just going through how we can move through the day. I'm not going to do that again. And this child was a child that had zirconia, but again, I anesthetized one side, fixed this, went and checked some of our recares, went back, anesthetized, and then did the zirconia on that side, and he did very well. Just a reminder about the mucogingival junction. You cannot cross it with intraosseous anesthesia. So again, if you feel like you're not getting profound anesthesia, it's probably you're not using enough solution, or you are not in the right spot, or you have the traffic jam or the interstate exit. So maybe you need to do another injection. The angle of your needle, make sure you don't pass all the way through and you're out of the bone when you deliver it, and make sure you're not doing intraligamentary. Remember, this is not a block. It doesn't last as long. And especially if you start transitioning to 1 to 200,000, like I hope to do, it's certainly not going to last as long. And just remember that if you choose to switch to 1 to 200,000, make sure you're not using that for other conventional means, because it's safest for children with 1 to 100,000. And I just say, surrender to mastery. It's hard. Anything that's new, it makes you uncomfortable. What we do isn't easy. So stretching us, it makes it a little bit hard, but you can do it. You can reach out. There's only pluses for that. You know, the learning curve, the initial investment, that goes away. And then you're in good shape. So I'm going to go back. If you don't have, that's my mobile number. That is my email. I love hearing from everyone, because I think you asked really good questions that I didn't think about, or something I thought about and forgot about. And I can add to help everyone learn, because we're all learning together. And I'm going to turn it back over to the New Smile team. We can review changing it. We can review, go through one, slow delivery and watch the whole thing go down. We can do whatever you want, but I promised everyone I would wrap it up and leave my contact, and I did run over just a wee bit. So I'm going to turn it back to these guys, and let's hear what the comments lead us to do.
Absolutely. If you guys have any further questions for Dr. LaRee, feel free to submit them during this Q&A time right now, and we'll get those questions answered.
So Dr. Richardson asked, for those of us who are newbies, was the previous webinar recorded? The answer to that is yes, and we will have it posted here pretty soon on our website. But yeah.
Looks like we also got a couple other questions, LaRee. It says, Dr. Taylor Winley says, I rarely get palatial blanching. Any techniques to improve my success rate?
Taylor, do you say you really do, or you really don't?
Rarely
Rarely do.
get palatial blanching.
You
Any
know,
techniques to improve.
That used to bother me a lot. For restorative, it doesn't bother me a single bit now. To be completely honest, Taylor, if I'm doing tooth removal, it will make me very suspicious that I either have a traffic jam or I have a traffic exit. And so I might choose to drop on the alternate side of the tooth and add a little bit more just to make myself feel better. But you don't have to have that to have successful local anesthesia, specifically for restorative. And Dr. Prin would tell you even for surgery. It just makes us feel warm and fuzzy when we do see it.
Okay, and then one other from Dr. Laura. What solution do you use for children under 4 years? 1 to 100,000? Question mark.
All right, Laura. So right now I use 4% articaine, 1 to 100,000, basically on everyone because I am not doing any conventional local anesthesia anymore on the little kids. I'm doing all intraosseous. So I feel very safe with it. I choose to do that. I have a pile of articles that I've studied and looked at, and I feel good about that. I think for me, the next journey will be with the bigger kids and the more, MOD, OB and a MODO and maybe a facial composite or something, experimenting with the 1 to 200,000 with 4% articaine. So I can still just do one injection and feel really confident it's going to get everywhere I want to go. Keeping in mind, it'll shorten my working time, but I work pretty fast. But no, little kids right now, that's what I'm still doing is 4% articaine. Everybody gets that 1 to 100,000. It's a good question though.
Okay.
And
I've abandoned lidocaine.
Dr. Weeder also had a question. They asked, any tips or pearls of advice for painless injection to begin procedure? I seem to hear a few ouches from kiddos at the beginning of injection.
I would, and Greg, you please call me, text me. I would wonder, are you being generous on your nitrous oxide? Do you have adjunctive things? Do you have an in-provider practice where all your colleagues dump the hard friends on you? What's going on there? Because we do have, there's always going to be those spirited children and their temperament is such, there's no matter what we do, they're going to be just a little bit fussy. But if you're using Epitech needles and you're doing something adjunctive, for us, it's yoga bolsters, weighted blankets, generous nitrous oxide. And if they are fussy to begin, before we even do anything, I'm very comfortable using 70% nitrous to let them chill out and making sure their mouth is closed while they're soaking on that and doing my sleepy and then backing them way up from there. I don't leave them there very long, but just setting up for success. And I would also wonder, do you have a parent present that is projecting their anxiety so you're having a hard time settling your little friend? But I don't think it's your technique at all. But we can walk through some videos together and do some things if you like. I hope that helps. Call me.
Awesome. And so again, just if anyone has any other questions, please feel free to put them in the Q&A down below now.
Or maybe not apparel. Maybe someone wants to share their successes and they're just, getting more and more comfortable and they have something positive to say. Or maybe they want to share how long it took them to get comfortable.
Mm-hmm.
It takes a hot second, guys. It took you a little bit to get used to using a regular syringe. It's going to take you a little bit to get used to this one, but you can do it.
I did want to mention just one more time for anyone that had joined after we made the announcement at the beginning and before I could send my message. In order to receive your full CE time, CE credit, following this webinar, as soon as it's over, I'll run a report and I will send out a link that link will take you to a feedback form to actually survey, to fill out your feedback on tonight's webinar. And then as soon as I see that that is submitted, within 24 hours, I will send you a PDF copy of your CE form. So give me probably about an hour after this ends tonight to get it out. If you absolutely don't receive it by tomorrow morning or even end of day tomorrow, then please reach out to me. My email is in the chat and I will repost it here now. So if you guys have any questions or need anything else, you guys are more than welcome to reach out to me. There we go, just shared.
Everyone's tired, at least the East Coasters are. The West Coasters are ready to party. If you guys want to play that, I will again. If you just want to go back to contact, please call me. A couple things that I can tell you just walking through with colleagues are common troubleshooting. I think maybe not going deep enough, trying to leave too much of the needle out, using lidocaine, not using enough anesthetic, like using 1/8 of a carpule for a 4-year-old is, I would do at least a half. They're big enough to do at least a half and go ahead and do that. Or maybe timing out, treating it like a block, anesthetizing a child and walking away and coming back. I think that's in some of the issues with some of our colleagues. And then the whole cruise versus drive, you stick the needle in and you push it once, you're in cruise, but you don't see any action. So you don't think you pushed enough. So you push it again, but then you just turned it off. And I do that too. I still do that and I'm glad we're switching them all to drive, where I push it and I get impatient. And right as my foot's in motion to push it again to make sure it felt my push, then I saw it go and then I turned it off. So just a wee bit of patience. And I think we're all always a little bit anxious to do something a little bit different and new. Is there a question up there?
I was going to say we do have a comment that the videos are super helpful. So.
And we can add more videos. I would love to know, it was my Dr. Miranda Kolaski. I tried to do them fast and I had so many last time. And she said, maybe seeing one all the way through, but I know people get a little bit tired of watching. It doesn't take more time to do intraosseous anesthesia because you're not waiting for your anesthesia, but it does take you longer to deliver your anesthesia because you're doing it compassionately. When truthfully, if we were doing it 1 milliliter per minute, it would have taken us this long all the time. So just keep that in mind. But for feedback, watching them full or watching them fast, and doing that might be a thing. There's just so much to cover. I had so much awesome feedback from everyone. I don't want to take everyone's time by watching video after video. But fast or slow, I would love that feedback.
And LaRee, if you wouldn't mind sending me that video of Clark switching it between,
Yes.
I
do
would.
it right now.
Awesome. And I will send that out to, of course, anyone who reaches out to Chandler, myself, or Chris. We'll have that video for you guys.
Absolutely. I'm going to send it to you right now, Jordan.
Thank you. Awesome. I got that. Thank you, LaRee. So I'll again send it out to anyone who would like it. And LaRee, maybe you can speak on, I'm not sure if you mentioned it, but just to recap, kind of how long it took you to get used to using the device. And I know you put away the manual syringe for good. You didn't want to see it. You don't want to touch it. You committed yourself fully.
I ripped the Band-Aid off quick. I took Dr. Prin's advice and we opened up, I mean, except for in the OR and the surgery center, of course, but we opened it up and then unfortunately the manuals went missing. So that prolonged my curve just a little bit because we hadn't really kicked things. This was in March. Things hadn't really kicked off exactly all the way. in the country with dental high tech, so there was a little bit of learning curve on that. But once I committed to it, I mean, it took like a month to really start sizing up how I wanted to approach things and realizing that it wasn't see and shoot, hit here, half a carpule, call it a day. Then I started crossing over, and then I really started sizing up. Okay, this is a bigger kid, you know, maybe he has just maybe has this gorgeous blocky brachycephalic class 3 mandible, and I need to give a generous amount of solution in there to be able to get him profoundly numb for the 2 teeth forward I want and the 1 tooth behind on the mandible. And I think that's when you just really go to sort of a Zen space where you just start sizing up the situation, and it gets much easier. The other thing is getting comfortable with the foot pedal, understanding that you're on cruise, not hitting it again, being patient, that it's actually moving. The dot is blinking. It just goes slow because it's really compassionate to do that. And I can tell you to this day, I still over blanch and probably waste too much time there, but it seems to work really well. And I mean, I don't want to discourage anybody, but at the 6-month mark, I felt like everybody should just throw away, and the whole world should throw away their manual syringes and never go back. And I'm working in our practice. We're almost there. We're gonna get rid of ours, and we're all gonna do it, all 7 of us, because it's just so much sweeter for the children. And that's what's important, is just to be so compassionate. And we like fewer tears. None of us like to see unhappy babies. That's the worst part of our whole job. So that's a good thing. And the other thing is the safety. I don't want to get into the nitty gritty, but I had a phone consult with a hematologist the other day, and we were talking about hospitalization and treatment in the OR because of factor delivery. And if you have, you know, even a moderate hemophilia child, and you look at the guidelines, if you have to give an inferior alveolar, you have to deliver factor. But with intraosseous, you don't. So, I mean, just that in itself, if you see those that are medically compromised, it's so much safer for the children. And just thousands. I mean, I don't know how many people here see medically compromised kids, but factor delivery is thousands and thousands of dollars, and they have to do it before and they have to do it after treatment. It's a big deal. So the fact we can do intraosseous now is really good. And I look forward to when we have devices in the US where we can do it in the permanent dentition too, where there isn't any bone that we can't get through to be able to serve that population.
And LaRee, this is a question that I'm not sure you might have an exact answer to, but for the blanching and to, you know, the drop by drop anesthetic part, the first part of the procedure or the injection is, do you have an estimate of about how much of the carpule you're doing for that?
It's not even an eighth. I mean, it'll blanch with just a few drops. And I can tell you every single doctor in our office over blanches, because it's very intimidating to just do a little bit and then take that out and drop it into a kid's bone and no, but they're really okay. I mean, I still overdo it. So, I mean, 10 seconds tops, I would say. And I mean, it truly is drop by drop. It's not very much.
And Jen asked if there was any way you could go over one demo video that you might have and just kind of hear your commentary throughout it.
Jen, do you want to do regular speed, maybe? You can text me too. If you, let me see if I can find, I dropped one in here. Regular speed. Here, let's find it real quick. I re-uploaded it in my my downloads so that I could do that. We don't have to search through this. I'll turn this off and we'll talk through it. All right, so this little guy, and this was in June, so I've got three months into it here. So I have a pillow you see what I'm gonna restore on that tooth K. I'm drying it off. And you'll see I'm in blue. I'm using the inner petal of drop by drop. Poor little dry lips, little boop boop. The D, I'm spinning it. It's hard to see. I'm trying to focus on spinning it out. And now I'd probably even spin it out a little bit more. It's a couple months in, but you can see it's starting to blanch. I can make this even bigger. And that is so much more blanching than you ever need in the whole universe. I will let you know now. Again, this was June, and then I'm swinging it up and I'm popping through. Now this is a little kid, so it just went through like butter. If it were a bigger kid, I might do the Dr. Alp technique. You'll see that I'm in blue for bone on my Soan, and you can see that plunger is barely moving because I'm at the early slope of that speed for the device. And then now you'll see it just start picking up. And I'm talking to him, we're taking our time. Because of my stabilization with my thumb and the nitrous nose, that is the best angle I can get. Now I would probably try to loosen up the nitrous nose so I could push it out of the way a little bit and get up a little bit further. But a very, very good result. You can see the plunger making its way. I'm staying in blue. At some point, he is doing so well. You can see his little eyes. He's just a happy camper. He's watching Lego Movie or doing something there. He's just doing so well. I reach down and I flip it to pink and let it take off. And if I had the sound on, and I flipped it to pink, I think he was kind of like, made a little noise. I flipped it back to blue. Maybe sometimes you see that, sometimes you don't. My videographer is losing me there for just a minute, and you can see him just, it's very, very, very slow. And it's okay though, because you're just sitting there, they don't feel a thing, everybody's happy. Have about 2 millimeters sticking out of the tissue right there, making my way in. I find that on the mandibular arch, especially trying to, when I do the intraosseous approach, I need to be more cognizant of the nitrous oxide nose. And when I show these videos to Dr. Prin, he points that out too. And you'll see in those European videos, those kids, they don't do too many adjunctive things. I don't see all the bells and whistles like we do for the kids in the US. One thing I notice, like I would be, if I were treating, let's say L was a pulp crown and this was a bigger kid, I would say I'm aiming a little bit favoring my K. I mean, it's going to absolutely dissipate through there. But if that K had an abscess or something, I would probably need to reconsider how I approach my L as well. And these are things, now this is just really easy. What you see, that little occlusal is the only thing I needed to restore. So I knew I'd be in great shape, and I'm approaching this half carpal. For something this simple, where I'm at is probably good. And you can see, I think you can see in this video, there's a little tiny bit of blanching, you notice. Give him a little drink of water. I didn't let any solution escape. I wiped after. He's just having a little drink. And then I'm going straight to the raincoat isolation. We're going to put our little soft pillow back in. And he has no numb lip, no numb tongue, nothing. And I go straight to the raincoat and put it on. And then you'll see in just a second, as soon as I get that on, we're just going to pick up the handpiece and get to work. And he did great. And this whole procedure, I mean, I'm not even sure it lasted 5 minutes. And we're done. So handpiece, and then you'll see me just immediately. I think I actually video this thing through the whole thing, but I think I chopped it so everyone doesn't have to watch that. I don't know what we're doing now, maybe changing the movie, but there's no reason to wait. Fix the raincoat, and we're gonna get to work. Make sure my tooth pillow is stable, and off to the races.
And LaRee, can I ask, do you keep your setting at like a half carpial, 3/4, a full? Do you play around with that, or
I did that early on because I didn't really have the pedal all figured out, and they were all on different settings and different things. And honestly, it was annoying. I think Clark's idea for us of just all of us ride and drive, so we know when we pick it up, it's going to be where it's at. So no, I don't change the speed setting. I don't change the sound setting. I like that. I like the drive setting. The carpule dispensing, I kind of played with that a little bit early on because I didn't trust myself with it, but now I don't like that either. I just let it go and I take my foot off, knowing it's going to do a little wee bit more after I take my foot off. And Dr. Alp talked about that a lot. He said, I saw him in May, so I only had used it 2 months when I spent a bit of time with him in May. And he told me, you're going to get where, like, it kind of annoyed me. I had to search around for the pedal and make sure my foot was in the right spot. And now I can feel it just like it's the rheostat. I don't have to fish around for it. And that gets easier too. Those are good questions, though.
Do you kind of use that foot hook as, just kind of like a point of reference, especially as well?
The catch where you move it around.
Mm-hmm.
Yes, I mean, I can imagine someone texted me, they took that thing off because they kept getting tripped and they must be just dribbling it under their chair, moving it around without that on there. They have better stalker skills than I do. No, we use it. And Dr. Prin recommended, like, after you're done with your sleepy, just take your foot and set it completely aside. Oftentimes with these children, he's doing very complex implants and crowns and things. Oftentimes these children, we're doing 2 quadrants restorative. So I want it back so I can move on in a hot second. So I like keeping it by the rheostat, but if you're just doing 1 quadrant, that's really a good idea. Any other questions? These are all good questions. There's still a lot of people on, so they must be wanting something. I just want to make sure everybody's getting what they want. I see questions popping up. Are you guys reading them?
I was gonna say yes. Comments from Jen saying thanks for the awesome overview, and then we also had a comment from Dr. Greg Weeder saying that he's gaining confidence daily and truly getting comfortable with the sew on. Thanks for all your help. So yes, truly thank you for all your help with this, LaRee, Jordan as well, and Chris. I'm sure everyone is learning so much from all of you on all these products.
Yeah, it's like anything else that you're learning. I can tell you some people have texted me like, I feel like we're doing zirconia again and you're trying to talk me into it. This is way easier than zirconia crown preps, I promise you. Not that they're hard, but the learning curve to, the difference between becoming proficient with this versus full mouth space loss back-to-back zirconia crowns, it's exponentially easier. So don't make that comparison. You guys are doing great. All right. And if there's something specific, and if at some point someone just wants just videos of cases, we could do that. It's just a lot. It's like watching TV after a long day's work. So I might lose a bunch of you, especially if you are enjoying a grown-up beverage during this webinar, like so many I understand do. Some of you have texted me that you are, as a matter of fact. So enjoy that. I am not. So I'm here to answer your questions.
Just a couple more things. We'd get one more comment, and I did want to circle back as well to Dr. Jody Atzman. Since you had your hand raised earlier, we didn't see a question come through. We just wanted to make sure if you had a question, you're more than welcome to submit it, or if you'd like to ask the question, raise your hand again, and we can allow you to ask your question verbally.
I think Jody's was regarding the aspiration, perhaps.
Okay.
Yeah. But if not, please let us know.
Okay. And then in the meantime, then we did have another message from Miranda Kolaski saying, if you are using Insulite, I like to numb with Isolite in case I drop some anesthetic. The child won't taste it. Oh, no worries. Okay. Just wanted to make sure you're getting everything answered, Dr. Jody.
Awesome.
All right. I see participants starting to drop off now.
Yeah.
Yep. And that brings us to about an hour and a half. So that will be the CE that we offer. So again, once this closes out, I will send out a link to everyone so you guys can all complete the survey in order to receive the CE.
All right.
Look like, yep. Awesome.
All right, wonderful. Well, thank you all for joining us. If you have any questions, please feel free to reach out and enjoy the rest of your evenings.